Hi, hello friends. So this is Celestia. Today we'll be talking about acute rheumatic fever, guys. So acute rheumatic fever is nothing but it is an immunological disorder. When you see fever, you should never keep in mind that it is just a fever. It is actually an immunological disorder which is caused by hemolytic group A beta hemolytic streptococci, and which actually causes infection of a pharynx. So if you see a prior infection which leads to an immunological disorder, and it can affect the heart, then if you see heart, joints, skin, subcutaneous tissues, and it is actually as I said, it is an immunological disorder, right? So this immunological disorder is non-infectious, non-suppurative. It is actually a after infectious diseases like infectious pharyngitis or infectious streptococcal pharyngitis. After it occurred, after that, after 10 to several weeks, 7 days to several weeks, there is occurrence of rheumatic fever, guys. So this is actually rheumatic fever definition. So next one, if you see, the next one is the epidemiology. Epidemiology is, if you see, only between age of 5 to 15 years. Okay, 5 to 15 years, if you get a sore throat, you should for sure go and meet the doctor and see to it, because the age group of 5 to 15 years will only have this rheumatic heart disease, rheumatic fever. Okay, then genders, actually both male and female are equally affected, whereas in female it is mitral valve diseases and chorea, or which is very common, and males it is aortic valve involvement, guys. And if you see those are not much important if you won't go through it. And if you see the etiologically, as I said it is due to infectious streptococcal pharyngitis. So infectious streptococcal pharyngitis, it is caused by group A beta hemolytic streptococci, which has which is a there are lots of pathogenic strains, whereas in that particularly M type 1, 3, 5, 9, 5, 6, 18, 19, 25, there are lots of other reasons also. But whereas type 18 is very most virulent mucoid strain. Okay, and other than that, if you see, genetic influence is also one of the causes. Genetic influences means, like if in 70 to 80% of the rheumatic fever patient, it be as an inherited as Mendelian recessive pattern and favors genetic predisposition or autoimmunity. Then pathogenesis, if you see, we have just 5 stages. Okay, what are the first 5 stages? Immune recognition, immune circulation, cytokine release, antibiotic attachment, then T cell recruitment and C cell recruitment, CD4 and CD8 infiltration into the valve, actually. Okay, into the, and then there is neovascularization of T lymphocytes, and this T cells response to other cardiac alpha helic proteins, including tropomyosins and mite. So what happens is that when the streptococcal antibodies are produced, okay, so not produced, it is produced after exposure of the particular strain of the particular organism antigen. When it is exposed, this antigen, what will happen, antibiotics will be produced by the B cells. Now this B cells will have molecular mimicry. So molecular mimicry, or you can say antigenic cross reactivity can occur, guys. So if you see, streptococcal antigen like the M protein will be a very equal type, and what happens is this, and against this antigen antibiotic will be produced. So this antibiotics will have a similar, like a similar this antibiotics which is produced for this M strain will be same to that of the myocardium. Okay, so myocardium cells will also have I hope you guys are understanding. The M protein, against M protein, antigen will be produced, antigen will produce an antibiotics. So this antibiotics not only affects this M protein, it will affect the mitochondrium also. Next, if you see, cell wall C see carbohydrate, so antibody will be produced against it. This will go and affect the antigen, the organism, as well as the cardiac wall. And cytoplasmic membrane means glomerular vascular edema. Skin antigen means peptidoglycans. Hyaluronic acid means synovial fluid. So this there, what is happening? Antigenic cross reactivity between the streptococcal antigen and the corresponding human antigen. And if you see the pathology, you will see as of bodies and verulae, or it is a vegetative around the line of closure of mitral valve. And if you will get buttonhole stenosis also will be seen, guys. So what are the risk factors? Like if you get an upper respiratory tract infection, it is a risk factor. If you are in poor socioeconomic class, seasonal variation like high incidence in falls, winters and early springs, temperatures like subtropical and tropical, then if you have prior epidermis of streptococcal throat infections, then if you have any hereditary predisposition like HLA association is saying, like it is 7 times more common in instance of monozygotic twins, and previous attack carriers also are more common. And if you see the clinical features, guys, like after the infection, as I said you, 10 weeks or about 1 to 5 weeks after the initial affect with pharyngitis, you will have the symptoms of this, okay. And the family history of rheumatic fever must be actually asked. Then we should ask about the evidence of pre-existing streptococcal infections. Like, so how will you identify the preceding? We will ask whether there is fever. Along with that, if you see, there will be increasing or rising of anti-streptolysin O titer, or increasing or rising of anti-deoxyribonuclease B, and there is positive throat culture for hemolytic group A beta hemolytic streptococci, positive rapid group streptococcal carbohydrate test also will usually be done. Next, if you see clinical features, next you should mainly see on a criteria. What is the criteria? John's criteria. So John's criteria, if you see, it is actually, before it was classified in a different way. Right now it is classified in a new way, okay. In 2015 it was classified. And if you see, first rheumatic fever outbreak, if the area is for first outbreak, it is the first one. In that place, if you see, you just need two major, one major plus two minor is needed. Where it is a relapse. Recurrent means two major or one major, two minor, or three minors are also, we can say it is a relapse of rheumatic fever. So what happens is that we have divided into low, so those area which comes as low risk areas, this comes as high risk area. So low risk means you have carditis, here also carditis you have, then here arthritis you have, here also you have arthritis, here you have chorea, here also you have chorea, erythema marginatum you have, erythema marginatum, subcutaneous nodule is also seen. But whereas in minor criteria, here polyarthralgia, multiple, like low risk is multiple, but when a single joint is involved, it is monoarthralgia. Fever will also be seen, here also fever will also be seen, greater than 38.5 degrees Celsius. Elevation of ESR, it is greater than or equal to 60 mm in first hour, here also 60, and same thing, okay. Then prolonged PR interval, corrective for age, like depending on the age there will be prolong of this one. Here also prolonged PR interval was seen only when there is no this is like only when there is no carditis, okay. So here if you see, only the difference is coming in what, the monalgia or arthralgia, polyarthralgia and monalgia, okay. And anything else you have it here or anywhere? Okay, that's it, guys. Next if you see, what are the terminologies? So we should remember a few terminologies in it. What are the terminologies? It's like reoccurrence. So reoccurrence means you have got an infection of acute rheumatic fever. After that, you're taking a treatment and you stop the treatment. After stopping of the treatment, within 8 weeks, you will get a new episode. Whereas rebound means 4 to 6 weeks stopping a treatment, you manifest for rheumatic arthritis. Like when you stop it, stop the treatment for about stop the treatment, and by 4 to 6 weeks if you again get it, again get the symptoms of rheumatic fever, it is rebound. Relapse means worsening of the symptoms while on treatment itself. Investigation, if you see, as I said you before, evidence of pre-existing must be seen, like what and all. ASO titer, next anti-DNase, anti-deoxyribonuclease, ribonucleases, I think it's ribonucleases B. And for example, you should see for total count, ESR, CRP, differential count, hemoglobin, and rapid streptococcal antigen, positive throat culture as is. Carditis, you should confirm it by chest X-ray and ECG and echo. Now if you see the treatment for group A streptococcal infection, see if you see penicillin G benzanthin, okay, group penicillin G benzanthin, it is an it is given by IM, okay, it is given by IM. It is about 1.2 million to 0.6 million units, okay. So if you see less than 27 kgs means you should give how much? You should give about 1.2, okay, you should give 1.2. Whereas if it is if it is greater than less than 27 kgs, you should give 0.6, 1.2, that is multiplication of both by 2. So 0.6 less than 27 kg, greater than means you should give 1.2 million units. If a patient is allergic, you should give erythromycin, azithromycin. Erythromycin is 40 mg, 4 times you should give daily for about 10 days. If you are giving azithromycin, 20 mg is given once you should give, and for 3 days alone it is given. If you have patient is having any hemorrhagic disease, you should give amoxicillin or amoxicillin or penicillin V. Here actually penicillin G we are giving, but here we are giving penicillin V. Next, if you see, actually the treatment is classified into treatment for group A streptococcal infection, suppressive therapy and supportive therapy. So suppressive therapy, it is like divided into 3. What are these? Is arthritis with mild carditis, or moderate to severe carditis, non-responders, okay, non-responders is divided in such. So arthritis a patient is having, along with that patient is having carditis. So in that case you can give aspirin base. Whereas moderate to severe carditis, like very severe means you should give penicillin. And if a person is not even responding, you should give methylprednisolone. And if you see arthritis and mild carditis, 100 mg per kilogram per day, that's all. As an aspirin, how much you should give? 100 mg per kilogram per day orally, 4 divided dose. Then you should tapering the dose of 75 mg must be 100, then for 75, that also oral. That tapering doses given for 4 to 8 days, okay, 4 to 8 weeks you should give. Whereas this is 3 to 5 days you should give this one. Okay, along with this you should also keep noting for ESR normalizing, whether ESR is normalizing or increasing or decreasing. You should alter the doses based on ESR. Okay, so aspirin we have learned. Next we have learned about penicillin, next methylprednisolone. So penicillin we all know 2 mgs, later on we should divide it into 4 divided dose, then we should reduce it by 5 mgs per day. Actually 5 mgs, not like 5 mg per kilogram, 5 mgs you should give, like what to say, you should give it, reduce it by 1.5 mgs, and here you are giving it for about 2 to 3 weeks. Actually here it will be given for 2 to 3 weeks, where this will be given for only 3 to 5 days. Then methylprednisolone 30 mgs, okay, 2 mgs, 30 mgs for 3 days you should give. Next, if you say supportive therapy, it is like best bed rest you should give, hospitalization in case of moderate to severe carditis, treatment for cardiac complications like digoxin can become salt restrictions, diuretics. Chorea means if your person is having chorea, you should give haloperidol 1 mg per day, that is 1 mg per day, not 1 mg per kilogram per day, totally 1 mg per day, 2 times daily for about 3 months you should give this. Then complications of rheumatic heart disease, like complications of this rheumatic fever is causing rheumatic heart disease, that is carditis. So what happens, what you should do, what happens is, like we'll see it in the carditis portion. Now here I'll just keep repeating it, like arthritis, congestive cardiac failure, infective endocarditis, rheumatic valvular heart disease, recurrent infection, and Sydenham cornea. Next, if you want to prevent this rheumatic fever, what all you will do? First of all, primordial prevention is there. Okay. Next, primary prevention. Primary prevention is like you should give penicillin G, benzanthin. That's what, less than 725 kgs means 0.6 mg unit. Intramuscular you should give, less than greater than 27 means 1.2 million units. A single dose only you should give. Whereas if a child is hemorrhagic or then that condition, we should give penicillin V. Penicillin V, we did not learn the dose, I think. We learned the dose. Yeah, penicillin we did not learn the dose. It is about 250 for children, and it is about 250 for children and 500 for this one, and orally about for 10 days you should give. If this is given and a patient has any hemorrhagic disorders. Allergic to penicillin means azithromycin must be given. We learned azithromycin how much, 40, but here you should remember in mind that it is between 15 to 20 mg per kilogram per day, not 40, it is 15 to 20, and it is given for about 3 days, and here you should keep it by 4 times daily. Okay. And if you see with allergic penicillin, we should give erythromycin or azithromycin. Azithromycin is another dose, but erythromycin you should give 40 mg. This is secondary. Here actually primary primary prevention you should give 50 to 20. In secondary you can give 40 actually. Then other remaining are same only, but only this is changing for secondary prevention. Okay. If person is not having any carditis, 21 years of age or 5 years from the last attack. Remember in mind, from the last attack 5 years up till 21 years, 21 years. Mild to moderate means 25 years or 10 years after the last attack. Here 5 years of the last attack, here 10 years of the last attack. Here severe, this is on a lifelong issue. Now what we will see, about carditis, guys. Carditis, if you see, it is also very simple only, seen in about 50 to 60% of children. Develop first 2 weeks of onset of rheumatic fever, pericarditis, myocardium, endocardium. So these all will be enlarged, actually inflamed in this condition. We have subclinical carditis, indolent carditis. Actually, to see whether carditis is there, you should always look for echo. Okay, otherwise it will be much visible also. Echocardiogram, if you see, endocarditis will be seen. You can see pan-systolic murmur of MR or ejection diastolic murmur of AR. You can see myocarditis, cardiomegaly, congestive cardiac failure, C3 gallop, S1 muffled, tachycardia. Then pericarditis is chest pain, pericardial friction prob, pericardial effusion. And if you see the symptoms, dyspnea is due to dyspnea can be seen due to congestive cardiac failure, syncope, pain due to pericarditis. And here you have mild, moderate and severe carditis. Mild is like you don't have any cardiomegaly. Moderate means you have cardiomegaly, and severe also you have cardiomegaly. Complication is mild, no complications, whereas in moderate you have cardiomegaly, whereas in severe you have congestive cardiac failure along with pericardial effusion. So here the treatment for mild is only aspirin, but here steroids plus aspirin, steroids plus aspirin. And here bed rest would be for about 4 weeks in mild, just for 4 weeks, whereas for 4 weeks means 1 month, whereas for moderate we should give it for 6 weeks. Till heart failure is controlled, you should give for severe carditis. Okay, then bed rest. Next, we should actually keep in mind the differentiate between rheumatic carditis and infective carditis. It's like what to say, DD. Okay. So rheumatic carditis acutely with patient will be infective endocarditis chronically. Okay, fever here in acute it will be not acute. In rheumatic it will be high grade fever. Vegetation will be very large, negative for streptococci. Okay, blood culture will show negative for streptococci. Verruae will be seen in the valves, and here it would be seen in ventricular valves. Okay, ventricular valve it would be seen, but here it would be seen in valves. Like wall, here infective endocarditis will be seen in wall, whereas rheumatic carditis will be seen in valves. And sessile, pedunculated, like in carditis it will be sessile, appearance of verinulae is sessile, infective one is pedunculated and friable, not friable, like those things you should see. And for mitral stenosis you should do balloon mitral valvuloplasty, mitral regurgitation, valve repair replacement. For aortic stenosis, surgical intervention in symptomatic cases, aortic regurgitation, prosthetic aortic valve replacement. So I hope you guys understood. And if you see the cardiac complications also will be seen: arrhythmia, congestive cardiac failure, infective endocarditis, rheumatic heart failure, recurrent infections. These also will be seen. So I hope you all understood. Thank you for watching. Bye.